Excellent. So welcome to the Healthcare Mavericks panel. As all of you know, healthcare is arguably the most important sector in terms of the impact that AI can have on the sector. Not only in terms of the cost of healthcare, but also much more importantly, the human and social impact it can have. And not least, the impact on the workforce. We all hear about burnout of the healthcare workforce and shortages in the workforce that affected different parts of the world. Niti was telling me earlier today that 1 out of 6 GPs in the UK are likely to retire in the next few years. And in the UK, there is already a shortage of 50,000 nurses. So AI really has a lot to offer there. Unfortunately, healthcare is also extremely overhyped when it comes to AI, and we've had a lot of somewhat unfortunate hyperbolic statements around digital doctors, AI replacing doctors, diagnosing better than doctors. And my team at IPsoft really prefer to focus on AI's potential to augment healthcare, really augment the human capital in healthcare, not only augmenting the workforce, the traditional social and healthcare workforce, but also augmenting the patients who are an actor in their own care, and also their informal carers who are increasingly being mobilized. And we really see a huge potential to augment the experience, augment quality, augment access, and augment, obviously, the efficiency in healthcare. And I couldn't dream of having a more wonderful panel to discuss this today. We have, these are all serial innovators, true mavericks in terms of really disrupting and improving healthcare. Niti, as the Global Medical Director for KPMG's Universal Healthcare Practice and multiple other hats and experiences in her career. Sumit, who is the CEO of a hospital-at-home startup called Carefully, and this is his 5th digital healthcare startup, as well as the Accenture Global Digital Health Strategy Lead. Russ Esposito, who is currently the CIO of the North American Partners in Anesthesia, and also has had a career in health insurance and as a health tech vendor as well. And Greg Miller, who's also a serial digital health entrepreneur and is currently the SVP International and Strategy for Health Catalyst, which is a very mission-driven organization, which is the leader in leveraging analytics to drive continuous quality improvement in healthcare with hundreds of providers in North America. So as you can imagine, as you can see, I'm very excited by this panel. And let's kick it off with Niti, and obviously there are different lenses that we can look at. Niti, I'd love to hear your perspective as you travel the world, in particular, in Southeast Asia and in Africa. What do you see as the potential for cognitive AI to augment the primary care experience, population health, and chronic decision support?
Great question, David. Thank you very much. So, primary care, I'm a primary care doctor, and I've been 33 years I've been a GP. I still occasionally see patients when I have the time, when I'm not sitting in a plane. My view is that, especially in emerging economies where I have a lot to do with, I'm working with Prime Minister Modi right now when he's announced 500 million people are going to receive healthcare reform of a benefit package of nearly $6,000 for a family of 4. It's the most massive healthcare reform I've seen in the world, and I've traveled in over 25 countries in the last year and a half or so. And I see in primary healthcare, we have a shortage of doctors and nurses and healthcare staff across the world, and by 2030, you'll have nearly a shortage of 33 million healthcare staff across the world. So it's much beyond these shores that we're talking about. It's not the mature markets we're talking about. We guys here have some degree of healthcare shortages for staff. But across the world, when you go across to Southeast Asia and to Africa, these are really compounded. I'd like to tell you a little story, if I may, David. The reason I'm doing universal healthcare, and that got me on my journey 10 years ago and why I'm wandering the world, is I was trying to put in primary healthcare in India, I'm an obstetrician by trade very long time ago, and I was in a village in Bihar where it took me 2 days to get on a bus to get somewhere. And a woman was in labor, and somebody came to ask me to come and have a look at her. And unfortunately, this was a young woman, 21, and I saw her bleed to death in front of me, and she lost the baby as well. The husband had 3 other kids to look after, don't know what became of them. And having been a doctor for 33 years, I was not able to do anything about it. But that was very avoidable. So for me, in emerging economies, it's not a question of a nice thing to have, or something that you might have tomorrow or day after. It's essential. It's a matter of life and death. It's not a question of today, it might come and make things better. So it's really important, I think, because this woman's death could have been avoided if we had had a virtual agent like Amelia or somebody else, or a primary healthcare system at the back end of a phone, which I've helped do in Bangladesh, where 5.8 million people are using it now. We could have predicted she had placenta previa. We could have predicted that she could have been sent to a local PHC. She could have been taken care of at week 22 of a pregnancy. A virtual ultrasound could have been done with some of the lovely things you've been telling me about, Sumit. So I think for a question of nice to have doesn't exist in these economies anymore. We simply don't have the doctors and nurses. So it's very important we start to look at virtual agents like this to augment the care that we've been talking about.
Thanks. And Sumit, it would be great to hear your perspective as you're innovating in bringing care in the home. And how are you thinking of the cognitive augmentation of that new model of care? It's not so new, but you're digitally enabling it. And what role do you see in cognitive agents in augmenting the experience, but also the scalability and affordability of these models?
Great, fantastic. So let me begin by just describing what we are doing. We're taking care back to a model that actually used to be pretty common, 100 years ago, except for the very wealthy. The very wealthy could afford to have a doctor come to their home when they got sick, and people who couldn't afford that wound up going to these places that became eventually these giant, very expensive, very inefficient, somewhat unsafe places that we call hospitals today, right? What we're doing is now taking the kind of care that very wealthy people could and still can afford in their homes and bringing that to everybody. Right? The idea being that if you wind up in the emergency room and you wind up there because of heart failure or a UTI or pneumonia or some other serious condition, and you're going to be sent upstairs to a hospital bed where you're going to be there for 3 to 5 days, the process, the benefit of you going home, both from an economic perspective, the cost of that care, and from a safety and convenience perspective for you as a patient, is just tremendous. The benefits there have now been quantified in study after study after study. And conservatively speaking, you can save about 20% of the cost of that admission by doing it in that home setting. And realistically, it's much more, right? So as we embrace this model, as we bring this model to life, one of the lessons learned from 5 generations of companies that I've touched is you can't throw bodies at this problem and hope to make this work. You've actually got to throw quite a bit of automation at this. You've got to be very smart about understanding what's happening, not just with the patient, but with an entire logistics framework surrounding that individual. You've got to make sure that the right thing, the right person shows up at the right place at the right time. And all of that, traditionally in healthcare, would have been done using brute force methodologies with some call center someplace, with some kind of the usual scheduling things, right? So that's where we found that if we adopted the kinds of technologies that are now possible with machine learning on the back end, watching what's happening, not just with patients, but with their entire care team and the entire supply chain, and with conversational agents engaging to relieve the burden on the care providers and the rest of the team that's supposed to take care of these individuals and also their friends and family. That all the folks involved in this journey become freed to actually practice at the top of their profession or care for the folks they want to care for, because the stuff that can be taken care of by automation is taken care of, right? So that's the basis for what we're doing. Now, one very interesting application is, so these are 3 to 5 day admissions in the home. And the patient shows up in the emergency room, set of conditions, they get triaged, and if they're eligible, then they have to consent, and then if they consent, if their home is safe, then they get put in an ambulance, and by the time they get there, the whole place has been hoteled, and sheets have been changed, and a bed might have been delivered, and so on. So that's the process. Well, imagine your parent, your grandparent making their way home in an ambulance. Would you expect them to use an app mounted on an IV pump to understand over the course of their 3 to 5 day stay what they're supposed to do, what's happening to them, what comes next? Would you imagine that they'd even get comfortable with learning the features of an app hanging off that IV pole? Or would there be something far more intuitive that might be available to them, which is, an agent that just talks to them, that reminds them when it's time to do certain things, reminds them when it's time to get up and move around, or when it's time to take their medications, that responds to their questions. Hey, when's Nurse Betty showing up? Hey, when am I supposed to take my meds? Hey, remind me, right? Or, hey, I didn't like my food yesterday. What can I do about it? Hey, my patch itches. Can we do something about that? And then there's a conversation that happens. And that conversation is not dead-ended in the sense that, you get some answers and then you still have to go figure out what to make of them. But that conversation then extends into the back office, where if that patch needs to be replaced, well, the next time Nurse Betty shows up, Nurse Betty's going to bring a patch, and all of that gets scheduled. Or the meal gets changed for the next day automatically behind the scenes. That's where this augmentation that you described, which is not just of the physician, but the entire care team, which includes the patient, the friends, their families, that's what we're enabling here.
Thank you. And Russ, you have a distributed workforce across hundreds of provider settings. How are you thinking of using cognitive agents to support that workforce and relieve them of the burdens that they face?
It's a great question, David. So we have about 2,000 anesthesiologists and nurse anesthetists in over 250 locations, hospitals and ambulatory surgical centers. And you have to realize they're not in an office, they're not sitting at a desk with a computer, they're in an operating room providing anesthesia services. So how do we contact them? How do we work with them administratively? So off hours is when they have more time. That's when our offices are closed or we have skeletal staff. So if someone wants to reset a password because they're trying to finish their clinical medical education, or they're trying to just check their emails, or they want benefit information about the physician's own benefit. What's their PTO time? What's their health benefits? If open enrollment changes things, how do they contact HR when they're in the operating room all day long? There's also a very complex process for managing credentialing. So providers need to have their advanced and basic cardiac life support training renewed every few years. And it's a lot of paperwork. It's emails and faxes going back and forth. It'd be much simpler if they could call 24 hours a day, whenever they have time, when they're not in the operating room, and ask all these questions. Have passwords reset. A chairman or a chief of a department wants to disable a password. They could disable a password 24/7. They could even have that information go to our customer is the hospital, right? So they could have that information in an email, go to the hospital to alert them that someone left the organization, their password's been disabled. The hospital now needs to disable the password as well. So there's a huge compliance process that can be solved by this that is also obviously involved with HIPAA. So that's just the administrative side of it. Then there are many things we can do on the patient side. So we have a pre-surgical testing portal that patients go on. We're rolling out in July. Patients can go on, answer questions about their health, so our anesthesiologists can prepare properly for their procedure. How much more interesting would it be if they could call Amelia and have a dialogue and have a conversation about their health? Again, 24/7, and have that information passed to the anesthesiologist. Then there's the part of the post-procedure, pain management, outcome management. Have Amelia 24/7 talk to our patients about pain management or their outcomes, get that information to the right practitioner and at the right time. So there's so many things we can do, even interoperatively. You know, there are standards that anesthesiologists follow if someone has a cardiac arrest in the operating room or a pulmonary event. There are procedures they can follow. They could talk to Amelia, someone who may be doing, let's say, endoscopy, endoscopic procedures or colonoscopies routinely, and now they have someone with a heart attack. They may not, they know what to do, but you want to make sure you don't miss any steps. Amelia will have all the information. And then finally, this repository of data, this adds value to the net worth of a company. You no longer rely on corporate information being tribal. You no longer rely on individual experts because there may be surgeons who are more anesthesiologists more specialized than others. You can capture all that information, whether it's administrative information about benefits and credentialing, or whether it's clinical information. That becomes a rich repository that never leaves the company, regardless of the turnover you may have in your staff.
Thanks a lot. And Greg, knowing Health Catalyst and the mission there at Catalyst being around continuous quality improvement. Quality is often about doing the routine consistently, right. What do you see when you work across the hundreds of hospitals that are Health Catalyst customers? Where do you see opportunities to improve operations and improve, care protocols and patient flows with cognitive agents?
Yeah, so good question. It's a complicated question because at the end of the day, when you think about patient care, it's very human intensive. And so when you think about the spectrum, it was the gentleman from Electronic Arts talked about the spectrum of self-service to live service. Healthcare is very much on the live service spectrum. And when you're sick, you want that kind of live service. So replicating live service with an electronic agent or AI capability is a difficult task. And that's why some of you may have heard about the colossal failure of applied AI at MD Anderson Cancer Center, where they came out of the gate and said, we're going to cure cancer with AI. What they neglected in that project was the human element of the fact that these doctors at MD Anderson Cancer Center are the #1 researchers in their field in the world. And suddenly they're going to be replaced by a artificial intelligence agent. So that didn't go over so well, and it was a $65 million failure. Instead, in our practice, we believe that machine learning and AI can universally and globally dramatically improve outcomes and reduce the cost of care. We believe it should be pervasive as well, but applied in a way that is very pragmatic and incremental. Not this big bang moonshot kind of approach. And so as an example, I'll just give you a quick story just about myself. 6 weeks ago today, I had a really bad crash on my road bike, and I spent 4 to 5 hours in the emergency department. And while I'm in there, they want to give me all kinds of drugs, and I kept saying no. But there was this argument I had 2 doctors and 2 nurses, and there was this argument amongst them about how I should actually treat all the wounds that were kind of all over my body. And when one would leave, another one would say, no, what you should really do is this. Then that one person would leave, and then the next one would say, no, don't forget, no, do this. And what would have, there are standards of care out there. There's evidence-based standards of care. And unfortunately, the average amount of time it takes for a new body of evidence to make its way to the front line for clinicians is about 17 years. Literally 12 to 17 years. So what if you could just turn to the agent and say, Amelia, what is the standard of care for wound dressing? And Amelia spits out the answer. That is leveraging off of data, a data-driven answer that is based upon evidence. That will dramatically reduce the variation in care as well as improve the patient experience. But the story gets worse. So I leave the ED in a lot of pain. I live about 10 minutes from the emergency department. I get home. By the time I got home, I had forgotten whether or not I needed to change my dressings that night. And it was this elaborate process. And so I was I just kind of lay down. I had my cell phone. I called the hospital again, and I said, I forgot whether or not I need to change my dressings. I sat on hold for 20 minutes while I'm writhing in pain, and all I wanted to do was go to sleep. And finally, they get back on the phone and said, no, you don't need to change dressing. Why couldn't have I had an automated agent where I say, Amelia, do I need to change my dressing today? Simple as that. So those are just pragmatic examples, but they're impactful because it affects the quality of care, the cost of care, the safety of care.
There's such a richness of opportunity in healthcare. And I think we all agree it's all about cognitively augmenting the routine. There's a lot of sexy things people can dream about and win Nobel Prizes and be on the cover of Science or Nature. But in healthcare, there's just a lot of routine and getting the routine right. And democratizing access, I think Edwin was talking about democratization, is democratizing access to the information and positioning Amelia as almost like the health whisperer. Like we have this notion of the whisper agent, and Amelia is the health whisperer who can whisper in the ear of the person in a village in Bihar who actually needs to know what the protocol is that they don't necessarily have, or to the patient who's wondering about what their post-discharge protocol is. So the opportunity is fantastic, and we look forward to working with all of you in training Amelia in those very important roles. So thank you very much, and please thank our panel, everybody.